Yeah, you can advance, yeah. Let's see, we can try. We can try here,
Yeah.
1 second. Ah, no, it has to be like this. No, 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 I don't need. Ah,
Try now.
capisci? Ah, che bello, bravo!
It's okay.
Molto intelligente.
So we are about to start the second session. It's a pleasure and honor for me to introduce Dr. Ghossein, a distinguished pathologist, a leader in the field of head and neck pathology and thyroid pathology, director of head and neck pathology department in Department of Pathology at Memorial Sloan Kettering Cancer Center. He doesn't really need any more presentation. Just follow the PubMed papers. You will find the man very large scientific and high quality scientific production. And so very warm welcome to Dr. Ghossein.
Thank you, Francesco. Thank you, Mattia, for inviting me, Dr. Barbarecci, for inviting me. Thank you for the Pezcoller Foundation. I'm very happy to be here in this beautiful city of Trento with all this beautiful nature around us. So before I start my talk on oncocytic and high-grade non-anaplastic thyroid carcinoma, and some of it is repetition of what Giovanni did, but it's a good thing. I really want to pay tribute to one of my teachers, and who was also Giovanni's teacher, Dr. Juan Rosai, a really proud son of Italy. He was a product of Italian immigration to Argentina at the end of World War II, an extraordinary career, very gifted young man who graduated from Mar del Plata University at the age of 21. He described 75 entities, including sinus cysticercosis with massive lymphadenopathy that now is called the Rosai-Dorfman disease, and his incredible gift and hard work fated him to be the chairman of the pathology department at Memorial Sloan Kettering Cancer Center, which is one of the 2 largest cancer centers in the world. And there we had the incredible privilege, me and Giovanni, to work under his directorship. And he also came back at the end of his life to Italy. So now let's start this talk, and maybe the best way is to start with this statement from the French-Canadian pathologist Pierre Masson, who said that there is no classification more difficult to establish than that of thyroid carcinoma. Of all cancer, they teach us perhaps the greatest lesson of humility. And so you don't feel bad if you find all this classification very complicated, but some of it is really important for our patients. So let's start with oncocytic lesions of the thyroid gland. We all know what an oncocyte is. That's the definition. Basically what it is, it's a large cell filled with a granular eosinophilic cytoplasm and with a usually large vesicular nucleus with a central nucleolus. And the reason this cytoplasm is pink because it's stuffed with mitochondria. Now I have to tell you the term Hürtel cell is a misnomer. The German pathologist Karl Hürtel, what he did, he actually described a C cell in dogs, and the name took off. But really it's another German pathologist, Askenazi, who really described oncocytes in the thyroid gland. That's why in the new WHO we dropped the term Hürtel, but I prefer to make the diagnosis say oncocytic X Hürtel cell carcinoma, because most clinicians still use the term Hürtel cell. So obviously these oncocytes can give rise to benign tumor, oncocytic adenoma, oncocytic or Hürtel cell carcinoma, but other things also, oncocytic non-invasive follicular thyroid neoplasm with papillary-like nuclear features. You can have a papillary carcinoma oncocytic variant. You can have a poorly differentiated with oncocytic features. And even when we look at one case tomorrow, even a medullary carcinoma oncocytic subtype. And you can have even so-called benign lesion, benign hyperplastic lesion with Hürtel cells. So what is a HER2 cell adenoma benign? So it's a benign encapsulated thyroid tumor composed predominantly more than 75% of follicular cells, and it doesn't have the nuclear features of the papillary carcinoma with, of course, no capsular or vascular invasion. This is a superb example here, a textbook appearance. And actually, in some instances, you don't have a follicular growth, you have a solid growth pattern. And why I mention that, because believe it or not, until the late 80s, some pathologists thought these are tumor of unknown malignant behavior. But now you can relax. Really, we are completely sure that the lack of capsular invasion and vascular invasion define the benign phenotype in oncocytic tumor. But believe me, my friends, this definition did not come easily. Just to amuse you, I put you the little quick brief story of the oncocytic cells. So Theodor Langhans did a lot of things in thyroid. He described HER2 cell tumors, and then somebody in the 1926, I think a German guy, said, all of them are benign. Then another, I think he was an American pathologist, said, all of them are malignant. I mean, it was crazy. Dr. Warren, who is the great thyroid pathologist in Boston in the mid-20th century, he called them, even very smart people can say stupid things, benign tumors with malignant potential. And, I mean, the American Cancer Society, they say something, another day they say another thing. 1951, finally, at Memorial, Fraser, a surgeon, said that vascular invasion is crucial. And somebody else thought that you can have artifactual vascular invasion. Well, you know, even in the 1970s, not that long time ago, there was a very well-known surgeon at University of Michigan who thought that every, every oncocytic carcinoma, every oncocytic tumor, if it was more than 2 centimeters, should be treated like a malignant one. So this thing took so much time. Finally, after 80 years, we all agree about that. So, and this is based on the studies by Dr. Ozai and his late wife, Dr. Kanju, Dr. Virginia Livorsi, who is still working at the University of Pennsylvania. We also did studies in the first decade of this century. So just to tell you that sometimes controversy, at least in thyroid pathology, can take decades to be solved. So Giovanni showed you what constitutes capsular invasion. This is what the vast majority of pathologists agree upon. There's still a minority of pathologists who think that you don't need complete or almost complete penetration of the capsule to call something capsular invasion. So these people will call it, if it is, I don't know if you can see, but it's here, like that. Like if it is mushrooming, but partially involving the thyroid. And these people are very prominent pathologists, like Dr. Livorsi. So this is a beautiful example of capsular invasion, mushrooming. Now, as Giovanni showed, this is what vascular invasion really is. So more specifically, the focus of vascular invasion, the vessel should be in the capsule or outside, and the tumor plug. And this is really important, so everybody please wake up. It should be either attached to the vessel wall, or covered by endothelial cells, and or admixed with fibrin. And this is an example of one of these cases. Here it's low power, but if you go on high power, you can see the tumor plug hanging in the lumen of the vessel and covered by endothelial cells. Now, there are certain situations where diagnosing any carcinoma in HER2 cell, in oncocytic cell, is quite challenging. Most of the problems come to us from the use of FNA, so we have to blame our cytopathology colleague for that. So, for example, you can have an adenoma that is completely infarcted by FNA. You have no idea even if it is a HER2 cell adenoma or not. Sometimes, you know, the needle track can display some HER2 cells that are really sucked or pushed in the capsule. And here the trick is really to look for fibrosis, inflammation, and you have some HER2 cells there. But this is not capsular invasion. Another common problem with capsular invasion is when you have a mechanical rupture of the capsule due to the surgeon or to the prosector. And you can differentiate this, we'll talk about later, by the fact that it's a sharp, abrupt interruption of the capsule. Another situation, but luckily it doesn't exist anymore, believe it or not, at a certain point, again in the 90s, even a little bit of irregularity is HER2 cell tumors. People used to panic and call them uncertain malignant behavior or carcinoma. Now, really important pitfall we have to all pay attention to is because HER2 cell tumors are friable, you can sometimes have clusters of cells in the vessel. This is completely artifactual because there is no endothelial cells covering, it's not attached to the vessel wall, and it's not admixed with fibrin. Finally, and also we'll talk about it later, you can have calcification in the colloid of HER2 cells. We don't know why. And these can look like some MOMA bodies, but some MOMA bodies diagnosed with papillary carcinoma are usually, should be in the stroma. So I went briefly on the controversial issue of what constitutes a malignant HER2 cell tumor. As I said, this thankfully was solved by previous generation of pathologists. Now let's jump to another issue that is problematic, which is the stratification of patients with HER2 cell carcinoma. The problem is this one. What does it mean? What does the term minimally invasive means? And Giovanni alluded to that, but I have to tell you a little bit what really happened regarding this controversy. It was not that easy to solve also. First of all, like everything we do, we have to think what is the clinical impact on the patient. So the term minimally invasive is very important because not all surgeons treat minimally invasive carcinoma with total thyroidectomy and radioactive iodine. So from the moment you label a patient as minimally invasive, a lot of surgeons will relax and will reassure the patients. So if you look at the latest American Thyroid Association guidelines, which is quite old now, almost 8 years, they will tell you that if you have in a follicular, they meant also in a HER2 cell carcinoma, capsular invasion only, or a few foci of vascular invasion, 1, 2, 3, less than 4, well, you can actually leave the patient alone. She mostly will not need a completion thyroidectomy with all its side effects. And remember, completion thyroidectomy and thyroidectomy in general is not a banal procedure. You can lose your parathyroid. There's something worse than using the thyroid in the neck is losing your parathyroid. You can lose your recurrent nerve, and you don't want the patient to say, "Thank you for saving my life," from a HER2 cell adenoma. So really, this is important stuff. So furthermore, the National Comprehensive Cancer Network, in the latest guideline, and actually 2023 is the same, basically, again, they tell you the same story. Minimally invasive for them is microscopic capsular invasion and less than 4 foci of vascular invasion. So before looking at what it means to be minimally invasive, let's remember what is widely invasive. You heard it briefly from Giovanni. So grossly apparent invasion of thyroid and soft tissue. Now this is a serious stuff here. You're talking about 50% mortality at 10 years. That's very bad for thyroid cancer. And often the growth is very interesting. The person growing the growth will tell you the whole thyroid is filled with tumor, and maybe I saw a capsule because this was the remnant of the capsule that was overcome by this proliferation. And often it involved the thyroid in a multinodular fashion. And almost always, I said almost always, there is a lot of vascular invasion. So think 25,000 times before making diagnosis of widely invasive without vascular invasion. But they do exist, and that's a problem we can talk about in the slide session. So you have to understand that hepatocellular carcinoma, when they are widely invasive, can give rise to real lymph node metastasis in a small proportion, 20%. When this happens, basically, the patient is in really, really bad shape. So one thing we all agree about thyroid pathology is what is widely invasive. Now, the issue of minimally invasive, the problem, there are various definitions. One of them is the definition that is present in the very influential Armed Forces Institute of Pathology fascicle that was written the last two editions by Dr. Zai, 92 and 2014. And in this edition, minimally invasive meant microscopic invasion, even if you have 10 foci of vascular invasion. So that's, in my opinion, I'm not a big fan of this classification here. I think it's not a great idea. Dr. Virginia Livosi from UPenn came with a much better idea, and she coined the term minimally invasive only to those cases with capsular invasion because they have similarly low risk. And when there is vascular invasion, she uses the term angio-invasive follicular or hepatocellular carcinoma. Now, at Memorial, for many years, I have been doing somewhat a variant of this. So minimally invasive, the last few years we defined only by capsular invasion for us, extraordinarily low risk of malignancy. And then I counted the foci of vascular invasion. If you have 4 or more, and I'll show you the Kaplan-Meier curve to prove it to you, it's really, there's a serious risk of a recurrence. If you have less than 4 foci, the patient is a much, much, much better category. So this is that paper that I did in 2006. In this paper, we took all the cases without distal metastasis presentation. That's very, very important point. Without distal metastasis presentation, they were all oncocytic, and I counted the foci of blood vessel invasion, and I'll show you how. And you can really see that those with 4 or more foci do worse. Actually, the exact recurrence rate, because this is, of course, a Kaplan-Meier, it's what's supposed to happen, it was half of the patient, no, a little less. 48% failed, but failed distantly. A really serious disease here. So I think that's why it's really not a good idea to use the term minimally invasive when you're dealing with extensive vascular invasion. Now, this business of counting the foci of vascular invasion was not an idea that came to me from the sky. It was done in 1986 by the German pathologist Walter Long. And what is fantastic that in his paper, he found approximately 5 foci, a little bit similar to what I found. Now, I don't know, Mattia, if you can let me say a joke here, but I'll let you know. So when I go to give talks and so forth, like maybe 15 years ago, 20 years ago, I was giving a talk, and I say, you know, Dr. Long was right. The problem with Long article that the big pathology guru of that time, maybe Giovanni Hedinger or something, dismissed that. This is junk, it's not important, but he was right. So I was saying that, and I say he probably is dead now. And I finished my talk, an old American pathologist who was of German origin came, like he said, "You were wrong, Dr. Long did not die." And, oh, really? Can I talk to him? Yeah. He gave me the phone number of a German associate pathologist, and I found him. So I called Dr. Long. I don't speak German. Surprisingly, for a German secretary, she didn't speak English. Said, yeah, Dr. Watergang. Then one who spoke English said, "What do you want?" I said, "Oh, look, I am doing research similar to Dr. Walter Long. He works here." "Yes, he works here. What do you want to talk to him about?" He said, "I would like to talk to him about his research." No, when it comes to research, he doesn't want to talk to anybody. So I'm saying to the young people here, including the resident who did surgery, so if a great person, supposedly an expert, makes fun of what you do, don't follow them, don't pay attention. They will probably actually, right, you probably hurt his or her ego. So that's the story of Walter Long. I never was able, now I don't know if he's alive, if there's somebody old here, but I think you and me were the oldest. Who knows Dr. Long, please let me know. So to bring this to life, so to speak, so this is a 50-year-old with a grossly encapsulated HER2 cell carcinoma, obviously. So here are these foci of vascular invasion. So as Giovanni said, every focus counts as a vessel. Again, it could be simply one vessel snaking in and out, but I have no idea. That's how I did the study, and it worked very well. Now, this is the problem. This was microscopic. So if you call this minimally invasive, you're in big trouble, because what happened to this poor patient? Bone metastasis 10 years later. They will come and tell you it's your fault. At least in the United States, the lawyer will say, Dr. Ghossein, we won't be here today if it was not because of you, and so forth. So really, we have to be very careful. That's now, we can say that finally this controversy is done. In the latest 2 WHO edition, and actually the 2017, Dr. Razai was in it, but unfortunately he passed away since then. There is no question, my friends, minimally invasive capsular invasion, only not even think of using that term for vascular invasion. Now, however, within angio-invasive, I really think that those with less than 4 foci do better, so it's much better to say, to count the foci of vascular invasion and to say if it's focal or extensive. And widely invasive, we know all how to define them. Now, let's a little bit jump to some molecular data here. So what I'm going to show you very, very briefly, you won't be sleeping. I'm going to show you data generated from our hospital, our group, but actually led by a surgeon, Dr. Ian Ganley, where he did an extensive, comprehensive genotyping of HER2 cell carcinoma. In the same time, the group from Mass General Hospital, Harvard Medical School, did the same study, and both papers were published in Cancer Cell in 2018. So we learned a few important things here. The first thing is that the genetic profile of oncocytic HER2 cell carcinoma is completely different from other thyroid carcinoma. For example, you have really much less RAS mutations than follicular carcinoma. So it's not, and I will show it to you with more data, it's not a subtype of follicular carcinoma. Furthermore, what is really interesting is when you look genetically at this tumor, they have something very weird. Like in many cases, in 54%, large number of chromosomes have one arm or the whole chromosome is lost. That leads to haploidy, loss of heterozygosity. You have one version of the gene. And sometimes you have something really cool called uniparental disomy. What does this term mean? That we all receive one chromosome from our mom and our dad, but if you lose one of them, that's the one from the mother, and then the one from the father duplicates. So you end up with one version of the gene with loss of heterozygosity. That is unique to this tumor. And of course, and Giovanni showed it when I was a fellow even, how many years ago, Giovanni, 30 years ago? There are frequent mitochondrial DNA mutation in this tumor. An important detail, though, you have mitochondrial DNA mutation in the benign and the malignant. It doesn't help you stratify the patient. Now, I'm going to tell you one quick thing, that this is a detail that may be important clinically in the near future. If all this complicated number, just to show that the PIK3CA pathway, PIK3CA, mTOR, etc., this pathway is altered one point or another in 55% of this tumor. And why this is interesting? Because one of our oncologists used everolimus, which simply an inhibitor of mTOR that I'm sure you heard about, and we were very surprised, Mattia, to see that a lot of patients responded. You have to understand this disease really doesn't respond to radioactive iodine. I mean, it was like a little bit magic. He didn't publish the paper yet, but hopefully he will publish a big trial. But hopefully this can give some hope to these patients. So, oncocytic carcinoma is different at the molecular level from follicular carcinoma. It's also different as far as aggressivity. In that paper that I published with my colleague, Dr. Bin Shu at Memorial, when you look at the encapsulated thyroid carcinoma, so this is basically encapsulated follicular variant, encapsulated follicular carcinoma, encapsulate oncocytic or HER2 cell carcinoma. The first that recur are HER2 cell carcinoma, because often they have more vascular invasion, but in this, we were lucky in this particular case that the follicular carcinoma, many of them had extensive vascular invasion, and they recurred later than HER2 cell carcinoma. This tumor is really different from follicular carcinoma. And finally, in this study, oh, let's see, maybe here. Okay, I see maybe. Oh, please, can you help us? I don't know why it's frozen. Problemo or problema, I don't know. It's feminine or masculine? No, huh? Problema. It's not fair. That's the problem is feminine. Oh, piccolo or problema? Yeah, if you can go to this one. Quickly, bravo. Yeah, no, okay, thank you. So in that study that we never published, unfortunately, because the endocrinology fellow was a little bit lazy. So this was actually, I thought, a very interesting study because we took Giovanni distant metastasis in patients, and according to the primary histotype, we tried to see if they pick up radioactive iron. Now, be careful. Picking up radioactive iron doesn't mean your tumor will respond to it. But just to give you an example, if you look at the blue mark, 38% of oncocytic carcinoma pick up radioactive iodine. Look at the follicular carcinoma, 100%. Now, if we, for those of you who are interested, you'll ask, what is the yellow? The yellow is the case, the percentage when the pathology, when the person who classified the tumor is not a thyroid pathologist. You see how it becomes different. That's why we need experts these days. Anyway, so the third controversy seems to be solved now. There is no question. Follicular carcinoma is very different from HER2 cell carcinoma at the molecular level in regard to radioactive iodine avidity and in regard to recurrence rates. So in the latest 2 WHO, there is no question about it. There are no, the HER2 cell is not a subtype of follicular carcinoma. So the last slide on this issue of oncocytic tumors is that capsular invasion, vascular invasion are everything, basically, and the extent of vascular invasion. But don't underestimate tumor. You will have, and I'll show you, tumor that have a little, only capsular invasion metastasized. But this is usually happens if there are distant metastases at presentation. Now, very briefly, regarding papillary carcinoma oncocytic variant, you have to differentiate it from tall cell because these cases are very different morphologically because in one case the cell is tall, in the other the cells are not tall. This papillary carcinoma oncocytic variant can grow as, can make papillae. I don't like to use this term, we'll see what Giovanni thinks, because I really don't think it's an entity, but so I'll use the term classical papillary with oncocytic features. They can have a follicular growth pattern. I will use the term follicular variant with oncocytic features. Okay, so that's what I wanted to tell you about oncocytic tumors. Now let's jump to another subject. So I always like to use statements here. So this is actually a say from Dr. Wallner. I don't know who went to the Mayo Clinic, but he used to be a well-known pathologist in the Mayo Clinic. He just died 2 years ago at the age of 100. So Mattia, if you're worried that maybe all pathologists die at 100, I hope. So anyway, so Dr. Wallner used to said that the clinician used to think that the classification of thyroid cancer was very simple. There was a group of well-differentiated, slow-growing tumor that never killed anybody, and a group of rapidly growing tumor that killed everybody. And here, to make a little bit joke, I remember Dr. Ozai used to tell us, I don't know if Giovanni remembers, that when he started to be interested in thyroid, I think maybe in the late 60s, early 70s at Washington University in St. Louis, Missouri, one of the surgeons made fun of him, said, "What the hell, why are you losing your time? There's nothing about thyroid pathology. There are slow-growing tumor that don't kill anybody and aggressive tumor that kill everybody." Well, that surgeon was wrong, and Dr. Ozai was right when he put this entity on the map, poorly differentiated thyroid carcinoma. So these are tumors of follicular cell origin showing histologic and prognostic features intermediate between the very indolent well-differentiated thyroid carcinoma and the catastrophic anaplastic carcinoma. And what Dr. Ozai did, he described the entity insular carcinoma with his wife and Dr. Zampi. And so insular, you guys know Latin more than me. Insular in Latin, I think, mean islands. So these are solid nests. Sometimes you have follicles inside. And what is really fantastic that this tumor is very similar to the one that was reported by Theodor Langhans. He comes again here. And now I hoped here that some people speak German. I think in German, I was told by my German colleagues at Memorial, this means proliferating struma. So what Dr. Ozai did, and he was very gracious, very honest, he actually even put in the title a redescription of Theodor Langhans' entity. So this tumor, the issue with this poorly differentiated carcinoma, the controversy, is that when there is a solid growth pattern, trabecular carcinoma, and necrosis, and you have invasion, and no anaplastic features, everybody agrees this is poorly differentiated thyroid carcinoma. But the problem, the rub, so to speak, is what do you do if you have solid growth pattern alone or mitosis and necrosis alone? What is more important, architectural grading, so to speak, or proliferative grading? So here I'm going to show you a few, what happened with this classification, how it evolved. So there was a very good article by Dr. Volante, I don't know if he's here, but from Torino, and Dr. Mario Papotti, very well-known, respected thyroid pathologist, long time ago, almost 20 years ago, where they said, okay, let's define poorly differentiated on the basis of growth pattern, and irrespective of mitosis and necrosis. And what they got is really tumor in between, like the Kaplan-Meier curve with an arrow here, in between the well-differentiated and the aggressive anaplastic. But when they develop a numerical scoring system, and the main component of that scoring system was necrosis, guess what you get here? Those tumors without necrosis even do better than papillary carcinoma. So I don't think poorly differentiated is a great term for them. And those with necrosis are really in between. So when I looked at this article, I told myself, well, maybe let's do like the opposite. Let's define them on the basis of mitosis and necrosis. I'm sorry, Giovanni, it's one of the rare papers I didn't do with you, but I'm sure we'll survive it. So what we got here, I chose a number, 5 mitosis per 10 hyperfeed. It wasn't, I didn't do any statistic for that. It was just my impression by looking at the cases of Memorial that did bad. And so mitotic count 5 or more, and or tumor necrosis. So what you get is the tumor that everybody agrees are poorly differentiated thyroid carcinoma, basically solid growth, necrosis, no-brainer. And here, this is really where I was in a distinct minority. So these are tumors with papillae that everybody will call papillary carcinoma, or follicles that everybody will call with follicles, but with necrosis. So how do these cases do? So if you take them as a whole, these cases, like the paper from Mario Papotti, 60% survive at 5 years in between well-differentiated anaplastic, wonderful. I tried to see what are the parameters that substratify these patients. Of course, things like extrathyroid extension margin important. These are always important in carcinomas. But what was more exciting, interesting, what did not make a difference, and here it is, whether you have a solid or a follicular papillary growth pattern, the tumor is going to go in the same direction. After this paper, a bunch of pathologists, international group of pathologists gathered in Torino, Italy, actually gathered by Dr. Ghossein, and they came with a definition that is a mixture of both. They say, okay, if you need a poorly differentiated carcinoma, you have to have a solid growth pattern, and you have to have absence of nuclear feature of papillary carcinoma. I respectfully disagreed strongly with this. I'll tell you why later. But in Congress with our idea, my idea, they said, okay, but you still need a high mitotic count or tumor necrosis. So let's see what does this definition do. Indeed, they have really captured tumor in between well-differentiated and anaplastic. But the same story, when you take out necrosis, when you start to play with necrosis and mitosis, the whole thing changes. This figure on your right, upper right, is of the non-anaplastic thyroid carcinoma, and the one with necrosis do very well. So despite, the fact that this was endorsed by, the best thyroid pathologist of all time, Dr. Ghossein, we still at Memorial did not follow that because we did study that showed that our definition, using our definition, it is the main cause of radioactive iodine refractory disease. If you die of thyroid cancer, is often through radioactive iodine refractory disease. Now, you have to understand here something important, that some of these cases, like this papillary carcinoma with necrosis, were called by some pathologists papillary carcinoma. Here you have to put yourself in the shoes of the pathologist. When he or she sees a patient, I'm not talking about pathologist that works at Tumori, or somebody who does diabetes and all kinds of endocrinologist that works at Tumori, so somebody who does diabetes and all kinds of things. So when he or she sees a patient with papillary carcinoma, said, congratulations, Mrs. Smith, or say here what, Mrs. Rossini, Mrs. Rossini, you have one of the most indolent tumor in the human body. When I retire in 20 years, my partner, Emma, will take over, and she will take care of you. We'll have a drink together. We'll drink one of the wines in Trento. And imagine, just imagine 3 years later, Mrs. Rossini coming back, not only with a recurrence, but on top of that, a recurrence that is refractory to radioactive iodine. And he or she has to tell her, oh, I'm so sorry, but you have to go to Tumori because we don't have targeted therapy here. It costs money. You're going to have to go to a hotel in Milano and so forth. So really, I thought this definition was a bad idea. I even took it a bit emotionally. So we did also another study where we found out that the main cause of death from non-anaplastic thyroid carcinoma. If you have anaplastic, unfortunately, you're going to die of thyroid carcinoma. But I will show you sometime you don't because you are lucky. But you die of it. But if you look at the patient who died from non-anaplastic thyroid carcinoma, non-anaplastic, non-medullary, 55% have mitosis and necrosis, whether they have papillary or follicular or solid growth pattern. So again, to bring this to life for you guys, I'm a little bit behind, but I think it's worth it to spend time on this. So look at this 72-year-old man with a 5.5 centimeter mass. He has a solid nested growth pattern, superb. You can see here, I'm sure Giovanni will agree with me, the patient has the nuclear features of the papillary carcinoma family of tumor, and the mitotic count is high. So if you use the Turin proposal, you call this solid variant of papillary carcinoma, which is not a bad, it's not a great tumor to have, it's not catastrophic, 90% survival at 10 years. But we will call it poorly differentiated. And what happens to this patient? Unfortunately, this is what happened to this patient. So the patient developed vertebral and lung metastases and died 4 years after diagnosis. So that's why in the new WHO, and I have to thank Giovanni for being on my side in that fight there that we won easily though, we came with a new idea. So we called all this intermediate prognosis thyroid carcinoma between well-differentiated and anaplastic. We call them high-grade follicular cell-derived non-anaplastic thyroid carcinoma. To make this diagnosis, you need to have invasion, and you need to have a high-grade feature, but in this case, it will be high mitotic count and or tumor necrosis. Again, I repeat, no anaplastic histology. Now, I guess, you know, in the WHO, it's all about compromise. There are two subtypes in this umbrella entity, the poorly differentiated and something called high-grade differentiated thyroid carcinoma. So let's read what they are. The poorly differentiated thyroid carcinoma is very easy. These are the tumor picked up by the Turin proposal. So again, I repeat myself, solid growth, no nuclear feature of papillary carcinoma, but necrosis and mitosis. And the other one are the tumor that at Memorial we still called poorly differentiated, but now we're gonna change the term because you know, at the cytoarchitecture level, they look like well-differentiated thyroid carcinoma. They make papillae, they make follicles, but they have a lot of mitosis and necrosis. So that's why we call them high-grade differentiated. That was Giovanni's idea, high-grade differentiated thyroid carcinoma, like the case on the top where you have papillae and necrosis. So at the molecular level, how do these cases look like? Well, at the molecular level, the poorly differentiated are mainly RAS-mutated tumor. So to make it easy for you, a poorly differentiated thyroid carcinoma is probably it's a follicular carcinoma that's gone bad, basically. Like 40 years ago, they used to be called follicular carcinoma. The high-grade differentiated thyroid carcinoma, the vast majority, again, probably papillary carcinoma that's gone bad, but really bad, with an 81% chance of having BRAF V600E. So again, what does this mean in real life? So with my colleague, Dr. Bin Shu, we did these very large studies last year, 364 cases of this high-grade thyroid carcinoma. So if you look at these two subtypes, the poorly differentiated is RAS predominant, I just said that, and it picks up radioactive iodine, and the tumor goes to distant met bypassing lymph node. But again, because there are follicular carcinoma that gone bad. The high-grade differentiated are BRAF V600E predominant. They don't pick up radioactive iodine, and they have a lower frequency of distant metastasis. The tumor goes basically to the lymph node first. Now, as far as death from disease, these are as bad. That's why I have been pushing for 16 years for this, because again, I don't want this patient to be labeled falsely with indolent tumors. So they have the same death rate. And just to really summarize all what I told you today, and to correlate morphology and molecular, so basically, if you want something really simple, you can look at this slide. So basically, you have RAS tumors, right? Like follicular carcinoma, encapsulated follicular variant. When they have mitosis necrosis, they become poorly differentiated thyroid carcinoma. You have BRAF V600E-like tumor, which, by the way, that include cases like RET PTC. I don't say BRAF is a mutation, BRAF V600E-like. It's coming from the paper, a very important paper done in 2014. So when you have, let's say, papillary carcinoma, classic, tall cell, or papillary carcinoma follicular variant infiltrative, he showed you a case, Giovanni. When they have mitosis necrosis, they are called high-grade differentiated thyroid carcinoma. You can say tall cell variant phenotype, or you can call it high-grade tall cell variant of papillary carcinoma. And, however, you know, these are the BRAF V600E-like family, RAS-like family, and in between, the tumor that are neither BRAF nor RAS, which are the oncocytic tumors. So here, when there is no mitosis necrosis, there are hepatocellular carcinoma. When they become loaded with mitosis and necrosis, then they are actually poorly differentiated oncocytic type. And at the end, they all, if the patient is unlucky enough, can end up being anaplastic carcinoma. So that's the easiest way to look at thyroid cancer. So this, I'm gonna finish with the last two slides. So you can see from the paper, from the talk that Giovanni gave you, and from the talk that I gave you, that really we're moving from an old classification of malignancy, including thyroid malignancy, to a new one that emphasizes prognostically relevant histologic feature than rather clinically irrelevant histopathology. For example, in encapsulated tumor, the nuclear feature don't mean much. It's really a question of capsular and vascular invasion, as it showed you, Giovanni. That's why the NIFT-P came. So same thing for mitosis and necrosis are very important. So we should not spend our time on unimportant things. And we really should always think about us as clinicians with a microscope. That's a term given by my vice chairman, Dr. Reuter. So basically, you know, like another person is using an X-ray to help the patient, or another person, she will be using the scalpel. We just using the microscope and the molecular features. So now this is the last slide of my talk. I like to finish again with statement. This is a statement from Julian Huxley, who was a British biologist, came from a family of British intellectuals, and he was giving a talk at the Sloan Kettering Institute, a few hundred meters, Mattia, from where my office is. Hope one day you'll come see it. And he said, it was in 1958, before I was born, maybe before you were born also, and he said, oh, come on. He said, cancer, malignancy must be defined operatively in terms of what the tumor cells do, not what they look like, otherwise the term ceases to have biologic meaning. If we had not obsessed on the nuclear features in encapsulated tumor, maybe we would not have overtreated tens of thousands of women with NIFT-P. I think basta for now. Now, okay. This is, as Giovanni said, entirely the clinical presentation always the same 66-year-old lady who comes with the thyroid mass. I even didn't say what Loven. All right. So here we're gonna please the older people or senior people. Let's go and ask, where is she here? This very smart resident. Okay. Actually, it's difficult. Okay. So this is, I can't, come on, everybody agree this is a tumor, no? I mean, even my grandmother would make this diagnosis. Okay, so, my nonna, sorry. So, all right, what type of cell this is? Well, you don't have residents, no? They're all cutting specimen? Nobody's here? Okay. I'm not gonna ask Giovanni because he knows everything, huh? Okay, nobody. Okay, so this is an oncocytic Hurto cell. It's not that easy to make the diagnosis, but because sometimes the nuclei look like papillary carcinoma nuclei. So the issue here is to have a round vesicular nucleus with a large nucleolus. So I guess we are fine with this. I don't know how to zoom out of this now. Yeah, with the mouse it will be easy. Let's do the mouse. Okay. It's okay, I'll have Purell. Grazie mille. Yeah. All right, let's go back to that guy. All right. Okay, how many people think it's cancer? Does anybody think it's not cancer? Okay, no? All right, so I guess if it's not cancer, it's going to be a goiter. But, you know, goiter don't have usually vascular invasion. So we were talking, Maria Pia Fruschini, about this fight with the CAP. I'll talk about it later. But basically, look, this is a big vessel with endothelial cells. I don't know who came with this idea that if you have endothelial, it's not cancer. Actually, I saw a lawsuit in the United States of a guy, it was in 1990, Giovanni, and it was very interesting because he said follicular adenoma with necrosis. And he had missed like 10 folds of vascular invasion. And it was a horrible story because I remember the patient was a teacher, she had metastases all over. And first of all, to think, again, very important, guys, necrosis in endocrine tumors, stop me, Giovanni, I've said something. Necrosis in endocrine tumors is super duper important. I mean, like, I don't know if it exists tumor necrosis and a benign tumor. So so nobody wanted to defend this guy. So the guy who defended him was a guy in private practice that was supposed to be thyroid expert. He said, well, you know, it's because there were endothelial cells around. Now, luckily, another lawyer was a bit smarter. He said, well, the Dr. Rosai's fascicle appeared, remember in 92? He was so proud, he showed it to us. It was before Dr. Rosai's fascicle appeared where he said that it has to be covered by endothelial cells. So they tried to help him. Anyway, when I got the case, I called the guy, usually, that's to be nice, said doctor, whatever, he was an old guy. He told me, yeah, I know why you're calling. This is the 10th person. He was almost crying, an old man, it's devastating. He probably felt so guilty. And so, please, guys, you know, we spend our life over-diagnosing thyroid cancer, the ultimate failure. You know, your life will have no meaning if you, on top of that, underdiagnose aggressive malignancy. That will be the ultimate failure of your career. Yeah. You should take your diploma, you know, this beautiful Italian diplomas with a huge. Eddie Brogi has one, like, it's like a map, you know, like with I don't know how many Roman goddess on it. You should throw it in the garbage. All right, so now, since nobody's interested in this case, Giovanni, can you diagnose this?
If you go at low power, there is something that it's worth mentioning.
Yeah.
You see, you know, this is typical with oncocytic tumors, but not only. So this is what we would call a widely invasive
Bravissimo.
carcinoma.
Wow.
You see, there is multinodular growth. There are fibrous tracts. And actually, it's a beautiful case because you see that there is the transition from these nodules that are outside to those that still show vascular invasion, like the one in the middle, right? And this is a gross diagnosis. And as I said, often paradoxically, not in this case, but paradoxically, when you want to prove, you know, that there is actual vascular invasion, it becomes even difficult because they've all become like plugs. And these plugs have eaten up the endothelial cells. So you don't find the conventional features of vascular invasion. Not in this case because they're evident at the center of the slide.
So this patient, what happened to her, Professor Italini?
No, but the other important thing is when you have an encapsulated single nodule, you know, encapsulated single nodule angioinvasive with 4 or more vascular invasive foci, that's a different tumor, completely different from this one. So widely invasive does not mean a tumor with extensive vascular invasion.
Yeah. But it kills, both can kill. So just to let you know, Giovanni, this patient, she developed 3 years after mediastinal lymph node metastasis, lung mets, and 7 years after pelvic bone metastasis. Once you have bone mets in thyroid cancer, bye-bye, you know, it's finished. So now, there is a situation, here I'm gonna ask Giovanni, it is very challenging, where you have widely invasive tumor without vascular invasion. So 2 questions for you. Do you call them widely invasive? Second, if the surgeon, you know, a smart surgeon, like the one we have at Memorial, call us and tell me, well, 1 second, Ronnie, usually every time you have widely invasive, you have extensive vascular invasion. What does it mean? What should I do? Should I take the other lobe? Blah, blah, blah. So what, have you seen them and can you answer this question?
Yes, that is exactly what I was saying before. Exactly what I was saying. So widely invasive carcinoma are carcinoma that look like goiters, they're multinodular, and they're widely invasive. How do you diagnose them? I mean, because the cells look malignant, the nodules look neoplastic, right? So if I find vascular invasion, I comment on that. If I don't find it, I don't care. I call it widely invasive follicular carcinoma, period. Because, you know, I refuse to say no vascular invasion identified. The problem is that sometimes, just as I was saying before, it is even difficult to find it because, not in this case where it's evident, but often, you know, these nodules, which are nothing but tumor emboli within vessels, have eaten up the vessels, you know, the vessel wall of the endothelium. So that is personally what I do, right or wrong. You know, sometimes you can do, you know, smooth muscle actin to find the outline of vessels. There is a nice paper from Hopkins by our friend Bill Westren, which he did to prove that some of these emboli were in the
Yeah,
vessels.
yeah, but you can have lymph node metastasis. Yeah, yeah, I know. So yeah, that's an important point. So basically, often in this patient, you may have, like after 2 years, a resection from the neck. And the surgeon will tell you, he or she will tell you, okay, the lymph node metastasis. And then you say, but John or Betty or whatever, I don't find lymph node metastasis because they're probably, it's worse than that. I wish it was. It's basically, these are basically vascular invasion in big vessels. And they look, when they dissect them, like lymph node metastasis. Okay, so, but luckily this is rare these days because, you know, people go earlier to the doctor and so forth. I don't know in the third world countries, it might be very interesting to see how often how many cases they have like this. Anyway, let's look at this. This is a 42-year-old man with a 5 centimeter left thyroid mass. Here there is no gross invasion, I promise you. These are old slides because I wanted to bring you slides with follow-up. So, all right. Now, okay, so you see the issue here, the big question. You know, when you look at any encapsulated thyroid carcinoma, the first thing you should think about, like, especially if you're obsessed by getting sued, like all American pathologists, vascular invasion, vascular invasion, vascular invasion. Because that will make a difference. If you miss a minimally invasive follicarcinoma, nobody will take you to jail because nothing will happen to this patient. But vascular invasion, you will be especially extensive. So how many of you, we're going to play the same game we did with Giovanni. Yeah, how many of you will call this vascular invasion? How many will call no, it's not vascular invasion? No, aggressive people here. Okay, so I don't want to have my thyroid being looked by this. Okay, I'll definitely become cancer. So here you see Mattia, like the case Giovanni had. There are multiple points of invasion. Now, one little detail that me and Giovanni we didn't mention in our lectures, that the growth pattern here is solid. Now, I have to tell you that in that study in 2006 that I did, I found, Giovanni, a good, actually, strong, significant correlation between the presence of solid growth pattern and extensive vascular invasion. However, it doesn't mean if you have a solid growth pattern, it's malignant. Actually, it could be benign, as I told you in the lecture. But once there's a solid growth pattern, once the tumor is big, please go on your knees to look for, I mean, of course, if the capsule is thick, so you have to submit everything. Now, the issue about sampling, Giovanni did a wonderful talk about it. Now, in a few cases, you know what we're doing, Giovanni? We're doing the whole mount, like the one we do for the prostate. I don't know if it's good. Somebody should do a study. I know you're very interested by this. If you want, we can do a study on that. Huh? Yeah, you showed? Yeah. Yeah, yeah. The only problem, I mean, if you want to do immunostain on this, they don't like it, the immunohistotechnician. But what you can do, you can circle an area, and they will put the antibody in one area. Okay. So, who will call this minimally invasive? Ha, ha, ha. Don't feel bad. Even Dr. Ozai, the greatest pathologist of all time, used to call them minimally invasive. I don't know why you didn't convince him, Giovanni, not to call them minimally invasive, but that's okay. So, nobody will call minimally invasive. Yeah, they're not minimally invasive. So, you guys want to know what happened to this patient? All right. Multiple long mets. Okay.
Can I say something about minimally invasive versus widely invasive? You know, the way we diagnose and the terminology we use has evolved over the years. You know, before thyroid screening with ultrasound and FNA, I repeat, thyroid tumors were diagnosed by palpation, right? If there was a goiter and the goiter was hard, then the tumor had to be removed. That was still, you know, 1960s and 70s of the last century. So, and then at that time, there were two types of tumors. The ones that were grossly cancerous, the one that we now call widely invasive, again, a gross diagnosis. And then the other ones that were encapsulated. And those, as a group, used to be called minimal invasive, okay, for a long time. And these were the tumors where, you know, the widely invasive, as I used to say, are the tumors where you have to look for the capsule, which is not there anymore because you know, the whole tumor, thyroid is replaced by nodules of tumor. And then there were the encapsulated tumors that at that time were called minimal invasive because they were encapsulated, and then you need to look for invasion with the microscope, right? Now we have learned that because of prognostic implications, that if you have an encapsulated tumor, in quotes, minimal invasive of all times with vascular invasion, that's different than when you have an encapsulated tumor with capsular invasion only. So now we call encapsulated angioinvasive the ones with angioinvasion, and the other ones we keep on calling minimal invasive. I think it's
yeah,
ridiculous.
but Giovanni, sorry, with all
no, but let me finish.
It was
no, let me finish.
Okay.
But I think it is stupid. I think you should just call encapsulated with capsular invasion only, encapsulated with vascular invasion plus minus capsular invasion, then widely invasive. I think.
Yeah,
Minimal
so
invasive is
yeah. I mean, I'm happy you agree that we should not, because I tell you, I lived the case at Memorial. I remember very well. Actually, the surgeon was a fantastic guy. He was the chair of surgery, like an extraordinary surgeon, like the best surgeon in New York. So it was diagnosed by actually a friend of ours, a very good lady friend of ours who was in training, minimally invasive with extensive vascular invasion. So she did a very good job, and she called it exactly what they thought. He said, oh, because it's minimally invasive, I'm not going to do a completion lobectomy. And a few years later, there is something in the scapula. So be careful, because, you know, we cannot, now, of course, the new generation of surgeons are very anal, very OCD, very careful, but, you know, because sometimes these guys, or gals, they read the first sentence, minimally invasive, you know.
I'm not saying, I'm saying actually.
Yeah, I agree, yeah. I'm happy you agree.
The historical reason for minimal invasive is historical as opposed to widely invasive.
Yeah. But
now,
it was a big mistake.
Now, minimal invasive
sorry about that. Yeah.
means capsular invasion only tumors. So you might as well write, you know, encapsulated with no vascular invasion, which is what counts.
Okay. So next one, 66-year-old, like the first case, female with a thyroid nodule in lobectomy. With lobectomy. This thing. Signore or signor? I don't know how to say. Signore. I think should call the gentleman by his name. So I don't. I found the arrow. Scusa. The arrow came back. When you come, things get better. Okay. So this is encapsulated. All right. With, by the way, a solid growth pattern. Now, the nuclei are difficult to, it's an old case. At that time, you know, people were not careful. They used to let the specimen rot maybe on the bench. Anyway, who cares whether, to be honest with you, whether it has nuclear features or not? What I'm more interested in is the fact that, is this thing, sorry, here. All right. All right, so this thing, that boo-boo here, okay, how many of you will call this capsule invasion? Good. Yeah. Well, then we disagree. Yeah, so so basically, I'm happy that some people think it's capsule invasion, because for many years, people thought that we have, this could be due to tangential cut or stuff like that. But also, notice the shape. It's like the cap of a mushroom you pick up in the forest of Trento. So, and on top of that, there is a neocapsule around it. So Giovanni, that was the only thing in that case. And actually, it was called, was it called by me? Let me see what year it was. No, it was before me, 1988, before both of us. So it was called minimally invasive, and nothing happened to this patient. So, so we come back to the issue of capsular invasion is really very, very important. The presence of vascular invasion is very important. Okay, now let's go to, in the interest of time, to another case. This is now we're getting into unusual stuff. Okay, 63-year-old lady, she comes with a hip pain. Of course, they give her, at that time, Celebrex was okay. They thought it was osteoarthritis. Then it doesn't work. She comes back, and unfortunately, they found a boo-boo, a lesion in the bone, and they do an FNA. And you have oncocytic cells. So now this case was in So this case was in 2004. At that time, PAX8 did not exist, Giovanni, or so they did a few stains, know which one, and then the patient came to our hospital with a diagnosis of probable metastatic renal cell carcinoma. And then because at that time we had a PET scan, they did a PET scan, and something lit in the thyroid. So they took it out. Okay, now. All right, I can go on high power to show you that this thing is also oncocytic. It has a solid growth. Okay. All right, who will call this capsular invasion? It's not vascular invasion, I don't think so, because I don't see endothelial cells here. So the question, is this tangential cutting or capsular invasion? I mean, of course, the most important question is this the reason? I mean, I guess it's easy to what type of cancer she has in the bone. I guess, I have to tell you, we redid the stains and it was thyroglobulin positive. So now it's academic, really. So, but would you, Giovanni, do you think this patient, it came from there? Oh my God, I just told you that minimally invasive doesn't do anything, so I'm an idiot then. No, there wasn't. Oh God, after. I wouldn't put money into that. Yeah, so I think this is capsule invasion with the neurocapsule, but more important than that is the concept that, I just told you, just a slide, 1 minute ago, that if you have minimally invasive, you have nothing. Again, as I said in the lecture, it is true until unless you have distant metastasis at presentation. Often, this is not a problem, thank God for us pathologists, because the patient will come with pain. So I published a paper on that with my colleague, Dr. Binshu. We took all the cases where the T stage was very low, there was no vascular invasion, and distant metastasis. All of them, but not many, 15 out of 600 distant metastases, and they're all at presentation, Giovanni. But, from time to time, there are articles that shows you it's not at presentation. So now what our surgeons do, after any carcinoma, even if it is a banal one, they try to have a thyroglobulin level even after lobectomy. I don't know the detail, but they explained to me that actually, if the thyroglobulin is a high certain number, they will panic. They will try to look for the distant metastasis. So actually, I think there are probably some where the distant metastasis is not symptomatic, but they say they can pick them up. But this is really fascinating. And now what we found out in this paper, that often these tumor material are filled with fibrosis. So probably there's a form of regression here. Yeah. And more interestingly, we could genotype maybe 7 or 8. And now, Giovanni, you're going to be happy because they had RAS and TERT. By the way, almost all were RAS. There was not a single, no, one BRAF only. Yeah, almost all were RAS and TERT. But there were so few, I mean, I couldn't make a statement. But however, no, I know what you're going to say. If you have RAS and TERT, you cook. No, you can have sometimes tumor with RAS and TERT that are indolent. Well, we can.
Well, I showed you, I mean, if there is one prognostically relevant, because to some extent, RAS and RAS-like mutations, BRAF V600E and BRAF V600E-like mutations, like the rearrangements that I showed. I mean, you can tell from looking at the slide right? Because some are follicular pattern, the other ones are the conventional papillary carcinoma type of cancers. But if there is one marker that is really prognostically very helpful, is TERT promoter mutation, because those, and I showed that beautiful paper, and there are others, but the one is from Korea is the most telling. Basically, you know, they looked at survival in capsular invasion only, so-called now minimal invasive, encapsulated angioinvasive and widely invasive, and then they looked at the histologic diagnosis and the cases which had TERT promoter mutation. And TERT promoter mutated cases, you know, predicted better what happened to the patient than our histologic eye in classifying the tumor as capsular invasion only, angioinvasive or widely invasive, which is quite impressive. And that's.
But okay.
So before calling, you know, I can imagine that one can have a clear-cut, non-invasive follicular adenoma with TERT promoter mutation, and I would call it by histology criteria. But then, if I have the data, I would definitely, you know, make a note that the finding of this mutation, you know, is and now we have clinicians that actually tell us whether the tumor is TERT promoter mutated or not, because they know from the behavior, you know.
But be careful though, because well, you guys don't do genotyping on FNA, but if you have RAS and TERT, some surgeons will say, "Oh my God, I have to do." I don't know why you should do. Or BRAF and TERT, they will do a neck dissection and go aggressively and whack the recurrent nerve, whack the parathyroid. So I think we have to wait and we have to see. But definitely, if I have a thyroid node, I would not like to have a RAS or TERT or BRAF and TERT. TERT alone, I'm not sure it's that important. Now, I have just to tell you one thing. There is some hope. There is now an in situ hybridization, but not for TERT promoter mutation, to look for basically we can do amplification of TERT. And actually, we have the assay now. No, it's not the promoter, but there may be correlation. And we're going to do the study in a few months. I will let you know.
Yeah, but it has been shown, at least so far, you know, obviously, that the overexpression of TERT that could also be investigated immunohistochemically.
Talking about immuno or by in situ?
Immuno or also by they did RNA, I think, but not in situ.
Yeah.
That's not relevant. What counts is the mutations in the promoter.
Yeah.
I don't know. It's
okay, let's see. We're gonna try it. I'll let you know in 4 months. We have already. We're gonna cut the cases. Yeah, we have it. Yeah. So this case, by the way, Giovanni and the other. I tried to look. So why this patient? I was obsessed. Why this poor patient with such a small tumor is so unlucky? And well, solid growth. In the past, people used to think that if the HER2 cells are small, they behave worse. But anyway, the only thing I could find, there's a bit more Ki67 than usual, but to make a long story short, again, the only thing I found differently in those is the fact that they have two things: a lot of fibrosis and a lot of fibrosis and RAS and TERT. Okay. Now, this is really interesting case because it goes beyond pathology. It goes regarding ethics, regarding being neglectful in life, regarding being a bad doctor or a good doctor. Okay, so this is I think important for all of us, even the one that are gonna retire in a month. 57-year-old female hospital. I remember she was a nurse with our hospital. She had a history of breast carcinoma, fine, metastatic to axillary lymph node, unfortunately. 2 years later, she had a left neck mass. So this neck mass was sent, this neck mass was sent for frozen section. I don't have the exact, sorry guys. So this neck mass was sent for frozen section. Maybe this is the permanent of the frozen, but anyway, this, as you can see, it's a lymph node. All right, we all okay? All right. Who thinks this is metastatic HER2 cell carcinoma? Bravo. You see, this is a good doctor. I found him here. Are there other good doctors here? No. So, okay. So, guess what happened, Mattia? You see this, this is really, most of the mistakes, there are many lawsuits in the United States. They often call me, but I never testify on anything, but I tell them what I think. I mean, really many mistakes are done like this. So guess what? During frozen section, they even didn't bother. Now, I have to tell you, this is before we had scan slides in the United States. So this is a case from 2003. But still, it takes 5 minutes to send the technician to the slide room to pull the breast. The same hospital, she had the I don't know, lumpectomy, mastectomy. They didn't bother. Allez, boom. They called it metastatic cell carcinoma. Also, the surgeon doesn't know thyroid cancer because metastatic lymph node, you don't have it minimally invasive. You have to have a widely invasive tumor that I said non-nice, not fair for women. Your nonno can make the diagnosis. I mean, like, usually it goes in the jugular vein, and he comes and tell me, Shahat comes and tell me, Giovanni, Ronnie, this is cancer, tell me what it is. So okay, congratulations, everybody. All right, so that's the first catastrophe that happened that day. What is gatto now? Okay, so, all right, so this is end up with a total thyroidectomy. Okay, all right. Total thyroidectomy. Oncocytic cells, right? I don't know, you want to compare both? It's kind of difficult. All right. Who think there is capsular or vascular invasion here? I guess nobody. I'm so happy for you guys. Yeah, this was not sent for frozen. This is where really things get bad in life, You have sometimes very smart people should not go into medicine. So he says, cell carcinoma. Said, my friend who made the frozen section, Mattia, is right. It is cell carcinoma that metastasized to lymph nodes. So I don't know if this is out of stupidity. Or I'm kind of suspicious here. You may think I'm a paranoid guy. I think they're, because that's maybe the problem of lawsuits in the center. It says they're so scared of a lawsuit, they lose judgment and they say, okay, there's actually now a big scandal about this in the United States with a very famous pathologist. I mean, you can become crazy just to cover a colleague. You're gonna go, this is like, go and cover like this and, right? Nobody would call this cell carcinoma, Giovanni, right? No. Okay. So, of course, when the case come to our hospital, so this is talking about ethics here. It's such a good lesson. So when the case came, of course, I made a phone call. It was 2003. And this was, my friends, the breast carcinoma. It was who is very good in breast? I think Maria Pia, right? So this is apocrine, am I right? Or I'm saying something stupid. Okay. Yeah, it was apocrine, and I don't know if there were androgen receptor in 2003. I don't remember, but we did all the stain, but absolutely no TTF1, no thyroglobulin. So this is a beautiful example, not a very sad example of how you make mistakes in life. So you're not careful, and on top of that, you don't give a damn about the patient, and you put the interest of your friend before the interest of the patient. If they find out that he did it to cover his friend, he can go to jail. But of course, it will never be like that. Now, I told the truth to our surgeons. We at Memorial are not a bunch of jerks who gonna go and but the surgeon and the clinician, the endocrinologist was very honest. He could have because in some places, and that's the problem with lawsuit, it showed the other ugly side of smart physician. Some oncologists would have told the patient, look, Mr. Whatever, Mrs., you can get to $1 million out of this, You can get, 1 million, go, no. It's like the jackpot, yes, winning the lottery. And they would testify, and usually when they testify in court, you can make, I'm talking about 15 years ago, $30,000. You can pay your opera ticket, you can pay your vacation in Trento and stuff like that. So they were very nice, our endocrinologists, and they told him even, they told, I don't think they should have, they even told the nurse, it probably was difficult, these are rare tumors, and she never sued because otherwise I would have been called. All right. So, but I thought this is important for young people to learn. Think 15 times before doing unethical things. I remember when I did, in addition to Giovanni, I did 2 years of research at Memorial, and there was this lady who was a researcher who gave us an ethic course, saying, you know, if you have a clinical trial and a randomized clinical trial, don't cheat and put your uncle who bought you your first car in the treatment plan. And then she said, if you want to cheat, think about one thing. I don't know Italy. In the United States, it's called the New York Times. One thing, the New York Times. Your career will be destroyed in like, as I told you about. Yeah. I don't know here if this exists anymore or it exists. What will be Corriere della Sera or no? Or you have to be the boyfriend of the prime minister to it. Okay. All right, a 59-year-old male. Now, okay, let's go to more interesting stuff. 59-year-old male with a growing neck mass. All right, so here we have a tumor. Who think it's cancer? Everybody, yeah. Okay. Again, Nonna and Nonno will do it. Okay. It's poor Nonna and Nonno, they get the bad. So, all right, so if you look on high power, this tumor has a nested solid growth pattern. I don't think, Giovanni, in the United States, they would think this tumor had the nuclear features of papillary carcinoma. No? Sorry, in Europe, no? They won't. No. Yeah, even us, we won't. And here. All right. Okay. How many of you would think this is tumor necrosis? What? You think? Yeah? Yeah, I thought too. Ah, you think it's not? Yeah. So maybe I can convince you. Okay. So everybody has a different threshold for tumor necrosis. So personally, I will call tumor necrosis if there is not a fibrovascular proliferation, because the only other reason to have a necrosis will be an FNA, really. So here there is no fibrovascular proliferation. It's kind of abrupt. And I don't know why, I don't know if Giovanni, you notice, sometimes the cell become clear next to the, and there are nuclear debris versus a ghost of cells. So I thought this is tumor necrosis, but I will love to have a discussion to see. Would you have called it, Giovanni, tumor necrosis? Or it's not very obvious, right? More careful. You're not that convinced. Yeah, all right. You can convince.
There are apoptotic nuclei. There is nuclear debris. I mean, the case that I showed before was kind of super didactic.
Yeah. Now another way is to see if we have a lot of mitosis. Now I have to tell you, my friends, that you can have a tumor with necrosis and with absolutely no mitosis, and vice versa. Don't think at all that they have to go together. Anyway, this unfortunate guy. What did he have? So this was what I thought Dr. Ghossein would call insular carcinoma, and he had, of course, extrathyroid extension, angio invasion. In 1 year, he developed vertebral metastasis, and he died 1 year and 8 months after diagnosis. Now, it could be not a fully different, I mean, it depends, but this is at least what I would think. If you consider this necrosis, this is what looks like insular carcinoma, right? Yeah. Okay. So, again, if we were in 1960, no, before Ghosein's article, which was, when was, before Ghosein's article, if we were in the 70s, this would be called follicular carcinoma. And yeah. Okay, now I became an expert in this thing. Okay. All right, now talking about Nonna. Okay, 92-year-old female with a left thyroid mass. So here, let's look at, well, sorry about that. Okay, so here you have solid growth pattern. All right, so another, since I talk all my life about necrosis and, okay, now let's ask our friends here. Who thinks this is tumor necrosis? Obviously, if you use my criteria, it's enough, but which, okay, Giovanni said yes, Mattia. But why guys, you didn't really agree with me? You didn't, you kind of not, and now you agree with me. What makes you, in this case, more confident?
It is a matter of...
What?
No, you go ahead.
Ah, more nuclear debris, yeah? That's, yeah. So you don't care so much about this vascular proliferation, guys? No, huh? It looks like you, okay. All right.
I mean, probably even the other one was, but it was less didactic. This is there are fragmented cellular debris in the background, and there are nuclear apoptotic cells, and it looks like it has this comedo pattern, which is also quite telling. Like comedocarcinoma necrosis.
Okay. Now, oh, sorry. Now, this is another area of the tumor. I'm sorry, it looks the same. My bad. Let's go to the next slide. This is another area of the tumor. Now here, there is no solid growth. The cells are oncocytic. It looked like it's making a papillae here, but I don't see, it's not obvious nuclear features, right? This is exactly what I was talking in my talk, I was saying in my lecture. It's like crazy. Here you have a tumor that you would think is a papillary, maybe a tall cell variant, Giovanni, and look, the nuclei are round. So this is what I call, in my consult, I call it mixture of phenotype in this carcinoma. And whenever you see that, again, you should really immediately think about an aggressive, high-grade non-anaplastic thyroid carcinoma. Actually, in this area also, there were a lot of mitosis. I'm not going to look for them in the interest of time, but you have to believe me for this. Now here, there is one feature that I think we all should look for in this tumor. So when you stain, so the big difference between this tumor and anaplastic, that this tumor, this high-grade non-anaplastic thyroid carcinoma or poorly differentiated thyroid carcinoma, but depending on the subtype, they stain for thyroglobulin. But there are two things you have to be aware of. The first one is that not all the cells stain for thyroglobulin. So don't be like, if you don't have all the cells staining, don't think you're dealing with anaplastic thyroid carcinoma. And then, I have to say what I put my, I found my dot, okay. There is one particular way it stains. It has this okay, maybe here. Fine, I think here. Well. Okay, yeah, here, finally, I want to show you. So, I don't know if you can see my arrow, but this dot-like positivity, here actually is even, in this case, is, see, where's the, okay, doesn't matter. Yeah, so here, I don't know, this is the maximum I could go. So this dot-like positivity, you see them in this poorly differentiated thyroid carcinoma and also in HER2 cell carcinoma. And you really should not look in these cases at thyroglobulin on low power. Many times I have pathologists told me, but I don't see thyroglobulin. It's a bit like when you're looking for chromogranin on synoptophysing dot-like positivity. It's a bit easier, but yeah. So two very important concepts. You don't need the whole, all the cells to stain for thyroglobulin. and dot-like positivity, please go on high power. So this one, by the way, is a tumor that can be called poorly differentiated thyroid carcinoma, and it can be called high-grade differentiated thyroid carcinoma. So it doesn't really matter. Probably what matters more in this situation is to know if it is a RAS or a BRAF tumor. And now we have a fantastic stain for BRAF. BRAF is on the E. You can use it. We also have a very good stain, I will show you later on, for RAS, Q61R mutation. It's not the best in the world, but it's very good. So all this can help us. But anyway, I would definitely, because that will tell you if the tumor is going to go through lymph node or through, or go to distant sites bypassing the lymph node. Let me tell you what happened with this case. Yeah, I don't remember. I didn't put what happened to this case. All right. So now let's look at a really, that's going to be a heated discussion, I'm sure. Okay, 49-year-old female with a right thyroid mass. I even remember her name, actually, because this was, oh, sorry about that. Okay, here. All right. So here you have an encapsulated lesion, and you have nested solid growth pattern. Okay, now, Giovanni and Mattia, if you don't think this is tumor necrosis, then you will never agree with me. So let's start the divorce proceedings. Yeah. All right. Now, honestly, with all due respect, do you guys think it's tumor necrosis? No. Finally. Ah, okay. So the problem here, Mattia, we have a big problem that I swear, you know, on everything I find dear, is that there was absolutely no capsular and no vascular invasion despite complete sampling of the tumor. So, what should I do? First, should I call this cancer or not? Because if you follow the WHO definition of high-grade non-anaplastic, I don't know if you noticed, I put invasion. We put me and Giovanni because I think I was the editor for this chapter and you wrote the chapter, right? Yeah. 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 So, invasion. You need to have invasion. So this, we cannot call it poorly differentiated because this will, if there is invasion, this will be a poorly differentiated thyroid carcinoma. Right, Giovanni, because it doesn't have nuclear feature, has solid growth pattern, is like everything the twin proposal wants. So how to call this tumor? At the WHO we had discussion. Some of the colleagues thought that it would be crazy to call this high-grade non-anaplastic because what if you have mitosis in young patients? You don't want to call a 20-year-old with high-grade papillary and destroy her life, the life of her parents. So we arrived to a compromise saying we will call them carcinoma with high-grade features and non-invasive. Let's say if you have a follicular variant with 10 mitosis, we call it papicarcinoma follicular variant with high-grade feature non-invasive. Of course, when every time I do that, I get a phone call. What the hell? What do you want me to say? No. So I tell you what I know about this, and here it will be interesting to see what the audience know about this, and especially what Giovanni knows. So, first of all, let me go into some things. So if you have a follicular adenoma, let's say a tumor that looks like follicular with high mitotic count, I do not call it even cancer. I call it follicular adenoma with high mitotic count. We can see how, yeah, in the past they used to be called atypical adenoma. I think with necrosis, to be honest with you, I don't have the guts, I'm not Superman, to call it benign, absolutely not. So what happened to these patients? So I did a study in 2012, I think, and actually we're very happy to see that this patient did very well. Actually, this lady, even remember her last name, as I said, 49-year-old with a right thyroid mass. I remember she was a mother also, yeah. NED, no evidence of disease after 11 years. Good news, no? So I used to put in my letters, you know, blah, blah, blah. These are, in our study, these have good outcome. However, the number of cases with number of cases studied is limited. So maybe it's better if you give the full-blown treatment. And my colleagues started telling me, Ronnie, stop overcalling this. You talk about overcalling. You and Giovanni did the NIFT-P. Now you should, you're really contradicting yourself. Until we had a case. It was a case of my good friend, Dr. Katabi here. And thankfully, she called it carcinoma. And it metastasized, Giovanni, after 3 years to the lung. It was an encapsulated follicular vein with solid growth pattern and mitosis only. And somebody in Italy, I forgot who, but they showed the case to Rosais, published in the International Journal of Surgical Pathology, a case with necrosis, so like this one, exactly like this one, without capsular vascular invasion, that more catastrophic, it went to the bone. So now, I have to tell you, we redid the study lately, and we found out that we have only one case that recurred. So the question comes, so one of the oncologic surgeon told me, hey, Ronnie, now you still want to call this high grade despite the fact that you have one case that recurred out of 30? I mean, it's a philosophical question, is out of what, 50? So sorry, Giovanni, to ask you the question since you are the expert in thyroid pathology. What do you think? What should we do? I mean, okay, if this person was your sister, you don't have a sister, but if you have only brothers, but what would you have? Would you do a complete thyroidectomy and radioactive iodine therapy?
So the question is actually kind of relevant. Is like Ronnie was saying, it is something, a topic of which we know something, but not a lot. So that theme is that of non-invasive carcinomas that have features of high grade, either in terms of mitosis or in terms of necrosis. So far, what has been written on the WHO, which is not, obviously, as some people think, the WHO are like, God's commandments on Mount Sinai. I mean, they're just guidelines, right? It's not like you have to follow every single detail of what's written in there. They just give you a menu of items that you can then apply to your practice. So after this sort of premise, I mean, in the NIFT-P chapter, actually, it is written that if you have, although with nuclear features of papillary carcinoma, if you have an encapsulated tumor that it is not invasive and that has increased mitotic activity, meaning more than 3 mitoses per 10 power field, then you call it adenoma with increased mitotic activity. On the other hand, if it is with nuclear alterations of papillary carcinoma, necrosis, or more than 5 mitoses, this is based on, published evidence, which is admittedly limited. You call it non-invasive carcinoma with high-grade feature, non-invasive encapsulated for your papillary carcinoma, if you want, with high-grade features. I mean, now, like Ronnie was saying, necrosis is a heavyweight in terms of prognostic impact, provided you are convinced it is real necrosis, basically all the cases that we have seen so far. The point is whether you find a lot of mitosis in a non-invasive tumor, particularly in young patients, and they do happen in the daily practice. So you call it non-invasive carcinoma. I mean, these are rare cases. I don't think there is anything, certainly you can use that term. It's on the WHO book.
I would definitely use that term because, remember, sorry, Giovanni, the recurrence here is not in a lymph node,
Correct.
The recurrence are a distant site. I mean, it's like serious stuff, huh?
N equals 1, though.
Yeah, 2, because the Italian case also.
The Italian case.
They showed it to Rosai, so I believe them. Yeah.
But it had necrosis, the one that was.
Yeah.
So I'm talking about mitotic activity only, non-invasive, encapsulated. You can use the term non-invasive carcinoma, but another way would be to say, describe what you see and to make a note that the rare cases with these features have metastasized. So that's.
So anyway, so basically, but you still didn't tell me what will be your recommendation: completion thyroidectomy and radioactive iodine therapy, or
it is a non-invasive carcinoma. Would be a carcinoma inside, so they need to be followed.
Yeah. So actually,
followed carefully, but
yeah, you're a genius, Giovanni, because that's what my colleagues do. That's what they do. And for them, if it is, he told me, if it's like one case or two cases, and one, so this is then like follicular carcinoma for me, you know. I mean, this is, how do you define an aggressive malignancy? How do you define malignancy? These are very important philosophical questions. Anyway, let's go to, we're going to finish very quickly, Dr. Foschini and Francesco, don't worry. I know everybody is hungry. Okay. Don't mess with hungry. How do you call people from Trento? Trentinis? Don't mess with hungry Trentinis. So, all right. Especially that I heard there are bears, so that I don't want to. 72 okay, so this is a 72-year-old male with a 5.5 centimeter thyroid mass and back pain. So this is here, actually this is the case that, I don't know if I need to show it to you, because this is the case I showed you in the lecture. So these are solid nested growth pattern with the nuclear papillary with high mitotic count. And this is just to show you the limitation of the Turin proposal. And this patient basically, unfortunately, had bone mets, and things went very, very bad. But let me show you two really unusual cases. This one, 50-year-old female with thyroid mass. And so this case was encapsulated, had a follicular growth pattern. Dots. Okay. Without full-blown nuclear features of papillary carcinoma, maybe there was. Anyway, it doesn't matter. All right. Again, my two friends here. Or let's ask the audience. Who cares about what Giovanni and Mattia think? Sorry, don't take it personally, both of you. So, who thinks this is tumor necrosis? Huh? Raise your hand, please. Only one. Oh. Okay. This is a doctor from Poland. Okay. So basically, yeah, I think tumor necrosis. Now I ask the two heroes here. So necrosis or no? Maybe. Okay. Giovanni?
Not very didactic, but probably yes, because I see their cellular debris. But you know, it would be nice to have an immunostain for necrosis, to be honest, for tumor necrosis.
Yeah.
And I can imagine that this is going to be an issue. But also the other thing that you said before, this is out of context. It's not related to, it's not an oncocytic tumor. It's not related to an FNA site. And it looks dirty. You don't see, you know, the cell ghosts. There are cells that have fallen apart.
Yeah, actually, you know, I put this picture in the WHO, I think. So basically,
to the right, actually, maybe. I don't know.
This one actually.
No. To the north of that, maybe. Where are you getting out? Well, whatever.
Yeah. Anyway, let's not fight on this now. We're all hungry and tired. But so, what basically, I can tell you what happened to this patient. Patient had a bone metastasis to the femur, I think. So this is one of these rare, in my opinion, you know, you saw a little bit the discrepancy of a follicular carcinoma with necrosis. And here, really, let's think about it. Although they are very rare, but why it's important? Because as I showed you in the lecture, the cases that we had who had follicular carcinoma, 100% picked up radioactive iodine. Before I looked at the cases, 92%. I took out all the one with necrosis, went to 100%. So now imagine this, again, it's the same story, you know. If this patient recurs, they will tell you, how come this is follicular carcinoma? If there's a tumor that should respond, is follicular carcinoma. So this will tell you that these high-grade differentiated thyroid carcinoma do exist. The vast majority are papillary carcinoma, but you can have some who are follicular carcinoma, and I think very rarely some HER2 cell carcinoma. Now, Giovanni mentioned something important, that be careful in oncocytic tumor, HER2 cell tumor, degeneration can look like necrosis. So maybe in oncocytic tumor, the threshold should be a little bit higher. Okay, now to make everybody happy, let's go to the last case, and then you all can eat. So this one is a really also interesting case. This is a young person, I think. Yeah?
Is there a question?
I'm sorry.
No, but the
other one?
The other one had vascular invasion or capsular invasion.
Ah, bravo. The other one, if I remember, definitely it had capsular invasion. I'm sorry, I don't remember if it had vascular invasion, but I remember it was called just follicular carcinoma. And the patient died after 4.5 years. And why I put this case, because exactly the clinician came and said, what the hell with you guys? You told me it's follicular carcinoma. It was not me, it was somebody else who made the diagnosis. We're not specialized at that time. I mean, I make mistakes, believe me, I make a lot of mistakes, but this one I didn't. And I remember, that's why I put it. And he said, what the hell, you know, this is supposed to respond. Yeah, sorry, I don't remember it was vascular invasion, but definitely there was capsular invasion. It was called follicular carcinoma, and by myself and another pathologist. Yeah. So this was just another way to show the limitation of the Turin proposal. Okay. So this one was a young person. Yeah, she was, oh my God, different terrible case. 27-year-old female, younger than your resident Mattia, with a 3-centimeter thyroid mass. So here, basically, this looks like what tumor, who likes GI pathology here? Huh? Looks like a tubular adenoma, no? Giovanni, you don't do GI pathology. All right, okay. Okay, here maybe it's, I guess you're not convinced. Yeah, much better here. Sorry, guys. All right. This, so this was called columnar cell variant of papillary carcinoma. Now, columnar cell variant of papillary carcinoma is an interesting entity because this is the first thyroid entity where we understood that the cell type, the tumor or the morphology of the cell type is much less important than microstaging. Because when this was described, it was thought to be a horrible tumor, 94% of, mostly in old men, 94% of distant metastases, like a catastrophe. And then Bruce Wenig, who is now the chairman at Moffitt Cancer Center, older than me and Giovanni, in Florida, did an article in the late 1990s showing that those who are encapsulated occur in young women, they are minimally invasive, nothing happens to them, and those who occur in old people are infiltrative and kill a lot of patients. And that's how the columnar cell variant actually, columnar cell variant was labeled as a aggressive variant of papillary carcinoma. But this is so an opportunity to talk about this aggressive variant of papillary carcinoma. If you look at this aggressive variant of papillary carcinoma, most of the time, they're aggressive not because of the cell type, not because they are tall cell, not because they are columnar. They are aggressive because of microstaging. They have a lot of vascular invasions, for example, or because of high mitotic count or tumor necrosis. Like in this case, where I have to find the tumor necrosis to convince you. I think I found it. Okay, we come to the same story with Mattia and oh, okay. I don't know. Sorry, guys, you contradict yourself because this has less nuclear debris than the other one. Ah, okay, you got me on this one. Okay, so yeah, this young woman, unfortunately, this young woman recurred twice in the neck. She developed PET positive. PET positive. When you have PET positive metastasis, it's bad news in thyroid cancer. In the lung, she failed to with radioactive iodine therapy. And luckily now, these days, it will be called high-grade thyroid carcinoma, columnar papillocolumnar cell variant, or high-grade papillocolumnar cell variant, high-grade papillothyroid carcinoma, columnar cell variant. And by the way, just a last word, talking about this hobnail that Giovanni talked about. Hobnail, when you have hobnails, it's usually, you know, according to a lot of studies, if you have more than 30%, you have the hobnail variant with an aggressive form. In reality, though, the aggressive cases almost all have mitosis necrosis, and you can have cases with much more hobnail than 30%, and nothing happens to them because they don't have mitosis necrosis. They often encapsulated tumor with hyalinization, and the hobnailing is just kind of endocrine atypia or degenerative atypia. So again, I hope that by the end of this lecture and these slides, you understood that we have to look at the cases in a different way. Don't like be swayed by, oh my God, hobnail is the end of the world or stuff like that. Just look, oh, I have nuclear features, so it's not fully differentiated thyroid carcinoma. Really, other things by far more important, as I said, microstaging, vascular invasions, everything. And of course, extrathyroid extension or the gross extrathyroid extension, positive margin or the gross positive margin, mitosis necrosis. And I didn't talk about it, but I want to tell you, regarding lymph node metastasis, the volume of lymph node metastasis is very important. Because, you know, if you look at papillary thyroid carcinoma in the 80s, they did study, they used to do neck dissection on everybody. Everybody has lymph node metastasis. It's with the volume that makes a difference. If you have more than 5 nodes, or if you have a node 1 centimeter or more, then immediately the patient is in a recurrence category. So I think we are on time, but if you have questions, please let me know. Basta. Thank you for uploading after 4 hours, 5 hours of thyroid. Any questions, anything?
Is this repository publicly available?
What?
This slide repository, is this public?
Is the slide repository available? I would think so. I have to ask the lawyers in my knowledge. Yeah,
Okay,
yeah. I
you.
think it is. Yeah, we can make it. We can make it available, but maybe I have to put that it is from Memorial on it. So not now, but if you want, I can find I asked the IT guys if they can put a Memorial logo so people don't use it to give conference. I had a friend of mine who went to Germany to give a conference, and then he said, and the young guy had taken his talk from the internet.
Thank you.
But it was very nice. Said, but just okay, sorry. Yeah. Okay. See you in an hour, right?